How are you?
Good, I'm good. All right, so welcome and welcome back for some others. Okay, as some of you already know, this is our pointer. And then this is our, for your PowerPoint, it's going to show here. The audience will see it there. Your forward button, your back button for your slides. Please remember that you cannot designate any unused minutes. Presentation here, but they'll see it there. And does anyone have a name that I could potentially mispronounce?
You tell us which names were hard to read.
Okay. All right. Well, thank you all.
All right, thank you.
Who's the ASAP person?
Hi.
Yeah. No, you?
I'm David.
Oh, hi, I'm Ray Pratt. I used to work for ASAP 20 years ago.
5-minute speaker? Okay. Oh, okay.
Since 08? Oh, okay.
Okay.
I saw you get it.
Yeah. And are you with you? Okay. Yeah. Okay.
Thank you. Okay, and I'll get the sheets for you.
Okay, we're getting ready to get started. If everyone could please have a seat. So welcome to the HCPCS public meeting, and this meeting is for drugs, biologicals, and radiopharmaceuticals. This is day 2. My name is Felicia Eggleston. I'm a member of the Part B drug team, and I'll be your moderator for today. So I would just like to let everyone know that this meeting is being webcast via CMS. The CMS webcast is live, so it begins when our meeting begins. By your attendance, you are giving consent to the use and distribution of your name, likeliness, and voice during this meeting. You are also giving consent to the use and distribution of any personally identifiable information that you or others may disclose during today's meeting. Please do not disclose any personal health information. The webcast can be found in archives after the meeting on YouTube or the CMS Ustream website, and I believe it is there permanently. Just some little housekeeping items. As you all came in, you passed the restrooms, so when you go out, you'll make a right. As you continue down the hall, the restrooms are on your left. If you continue on out towards the lobby, you make a right past the elevators and straight down those stairs that'll take you to our little coffee stand and the cafeteria. We have been asked to remind you that for security reasons, visitors may not enter any areas of the building other than the public areas unless you have an escort. If any of you or anyone with you need assistance in arranging for taxi service today, please see the concierge in the lobby. CMS is a non-smoking campus. There is a smoking area on both sides of the outsides of the gates and the entrances to the campuses. At this time, I'd like for you to please put cell phones and Blackberries on silent. I would like to also ask that all speakers and anyone answering questions please be sure to step up to a microphone so that we can hear. This includes outside participants as well as agency staff. I would like to also ask for everyone's cooperation in sticking to speaking time frames. Primary speakers have up to 15 minutes, 5-minute speakers have up to 5 minutes. So as you speak today, if you're a primary speaker, once you have 2 minutes left, you'll hear me ding a bell that lets you know to please begin to wrap up. Once the 15 minutes is done, I'll stand up and begin to approach the bench. So I'd like to also let everyone know that speakers may not call any other speakers, only the moderator can call speakers. So as we progress with the meeting, there will be a short coffee break in the morning, a lunch break, and if we're here late in the afternoon, then we'll have an afternoon break. At this time, I would like to introduce Cindy Hake. She is the Deputy Director of CM's Division of DemiPost Policy and of CMS's National Level 2 HCPCS program. Cindy will provide opening remarks and a brief description of the background and purpose of today's meeting.
Good morning, everybody. And welcome to CMS. We're happy that we could actually have these meetings this week with all that has been going on in Baltimore over the last couple of weeks. We were getting pretty concerned about whether people would even come out to this area. At one point last week, our building was actually closed due to the rioting in the city. But that seems to be at bay for now, and here we are. So thank you for coming, taking time out of your busy schedules to come and meet with us. We do take your comments very seriously. We are glad to have this forum. It's proved to be beneficial to the decision makers, I think, as well as to the applicants. So we do really, when I say appreciate that you take your time to come out and speak with us, we mean it. So before the public meetings occur, the HCPCS work group reviews all applications and formulates preliminary decisions that are included in your meeting agendas today. The work group includes members who represent Medicare, Medicaid, and the private insurance sector. We also have appointees from the Veterans Administration. So all insurance sectors are looking at the applications. We publish the preliminary decisions along with our rationale, and then via this public process, invite applicants and others in the general public to provide testimony that either supports or refutes CMS's preliminary decisions. So final decisions are not made today or at these hearings. After the public meetings, the HCPCS work group reconvenes and we reconsider each and every application before us, together with all the input we received as we begin to formulate final decisions. And sometimes our preliminary decisions do change, and that's testimony to the fact that we take your comments very seriously, and that it's a valuable, these meetings are a valuable process. So for those of you who are providing comments today, if you haven't done so already, please be sure that you give Jen Carver, our meeting coordinator, before the end of the day a concise summary of your chief points. And as you're up here speaking today, make sure you make your chief points very clear. We do, after the public meetings, publish a public meeting summary that looks like the summary that's in your agendas, but it will also include a brief summary of the chief points made by our primary speakers here at this meeting. Final decision letters and the annual HCPCS update are released in mid-November. We say by November 15th, hopefully closer to November 1st. And most changes to the code set that are made are effective January 1 unless otherwise specified. I'd like to take some, in addition to just publishing the annual update, we began last year, we made several changes that include publishing the preliminary decisions, the final decisions on our website. And so we did that last year for the first time. We do that in two formats. One is a narrative format that looks like the narratives in your summary, we add to it the final decisions. So that's kind of like a start to finish life of the application for the year snapshot. The other format is in a spreadsheet that includes the application number, the request, the preliminary decision, and the final decision. And so finally, after years of assimilating input and making improvements to our processes, based on your feedback, we have some feedback for our applicants that I'd like to offer, if I may, this year. That is that as the years have gone by, more and more applications have been coming in incomplete. And as a courtesy, our staff has been contacting the applicants and telling them the areas of the application that were incomplete and encouraging them to resubmit an application that is complete. However, because most often applications are submitted very close to the deadline, by the time we make that call, you haven't given yourselves enough time to react, to make your application complete and still meet the deadline. And so this is just sort of accumulated, and by this year we were spending a month of our time just assisting applicants in making their applications complete. And we don't have the manpower to do that. We have a small staff. We have a crowded schedule. When we implemented the public meeting process, and even more so when we expanded it for all categories of products, and managed to have this reconsideration process all still within an annual cycle, we kind of pushed ourselves to the max. So we have the staff and the manpower to manage this process for you. We don't have the staff and the manpower to do quality review on applications that are submitted to us. That really should be done by the applicants. And so because application completeness and timeliness is the first criteria in our decision tree, we will next year be not processing applications that are late or incomplete. And I know that you would rather hear that from me now than hear that from me in December or in January when we get an incomplete application. So just make sure that you do a quality review on your applications, if you would please. And I made this announcement yesterday, and somebody said, gee, does that mean that the May 31st or the March 31st deadline for FDA clearance for drugs no longer applies? No, that still applies. We're looking at the actual application deadline. That's usually within the first few days of January. Okay, that's all I have. Thank you.
Thank you, Cindy, for that overview. Now I'd like to introduce Marge Watchhorn. She is the Acting Deputy Director of the Division of Ambulatory Services in CM's Hospital and Ambulatory Policy Group. Marge will provide an overview of Medicare's Part B drug payment. A more detailed description of payment for Part B drugs is attached to your agenda today.
Thank you, Felicia. Good morning, everybody. So what I wanted to talk to you about a little bit today, briefly, is how Medicare pays for drugs under Part B. Generally speaking, we pay for Part B drugs using average sale price, which all of you are very familiar with. Medicare Part B covers a limited number of prescription drugs. Generally, these drugs fall into one of three different categories. First are drugs that are furnished incident to a physician's service. These are drugs that are not usually self-administered. The second category is drugs that are administered through a covered item of durable medical equipment, or DME, such as a nebulizer or a pump. Third is a broad category of drugs that are simply covered under Part B and listed in statute. These are drugs such as certain vaccines, hemophilia blood clotting factor, certain oral anti-cancer drugs, and certain other drugs that are separately billed by end-stage renal disease or ESRD facilities. So Medicare Part B does pay for most drugs based on ASP, but we pay for other drugs on a cost basis or a prospective payment basis. These are drugs that are furnished during an inpatient hospital stay other than clotting factor, drugs that are paid under the outpatient prospective payment system, drugs that are furnished by ESRD facilities, whose payments are included in Medicare's composite rate, and drugs that are furnished by critical access hospitals, skilled nursing facilities, comprehensive outpatient rehabilitation facilities, rural health clinics, and federally qualified health centers. Historically, Medicare Part B paid for most drugs based on a price point called average wholesale price, or AWP. The payment formula that we applied was 95% of AWP, and we received the AWP data from the commercial pricing compendia such as Redbook or Metaspan. And then in 2004, the Medicare Modernization Act began a radical shift in the way Medicare pays for Part B drugs. For the calendar year 2004, the payments were reduced for most drugs from 95% of AWP to 85% of AWP. And then in 2005, we switched to average sales price. Where do we get average sales price data? Well, the drug manufacturers report the data to us on a quarterly basis. CMS uses the ASP data to calculate the Medicare payment rate for Part B drugs. The formula we use for most drugs is 106% of the average sales price. For single-source drugs, Medicare payment will be based on 106% of the wholesale acquisition cost if that amount is lower than the ASP calculated amount. Now, the world of ASP is not static. We're continually reviewing our pricing and our coding determinations to ensure that separate and appropriate payment is made for single-source drugs and biologicals as required by statute. And as you all know, it may be necessary to create a unique HCPCS Level 2 code for certain products. I want to touch briefly on biosimilars. In accordance with the revisions made by the Affordable Care Act, CMS will incorporate biosimilars that are approved under the abbreviated biological license application into the ASP payment methodology. And we will issue additional guidance as necessary to inform you all on how we're going to apply that to biosimilars. Now, there are still a couple of exceptions to the ASP pricing methodology, and these drugs are still paid at 95% of the average wholesale price. These are vaccines that Medicare Part B covers, specifically influenza, pneumococcal vaccine, and hepatitis B vaccine, infusion drugs that are furnished through DME, and blood products other than blood clotting factor. And then the last thing I wanted to say was for radiopharmaceuticals. Payment for radiopharmaceuticals administered in the physician's office is determined by the Medicare Administrative Contractors, or the MACs. This has been true before the MMA was enacted, and in fact, the MMA had a specific provision in it which specified that the ASP methodology will not be applied to radiopharmaceuticals, and that pricing would continue the way it had before the MMA. So the MACs used to price radiopharmaceuticals, and the MACs continue to price radiopharmaceuticals today. So thank you very much.
Thank you, Marge, for the Part B drug payment overview. At this time, I would like to introduce other CMS HCPCS staff. Many of you have had the pleasure of speaking with them by phone or communicating over emails. So first, I'd like to introduce Ms. Jennifer Carver. Please stand. She is CMS's National HCPCS Public Meeting Coordinator. Next, I'd like to introduce Lori Jackson. And I'd like to acknowledge Ms. Kimberly Combs Miller, and she is CMS's National HCPCS Work Group Meeting Coordinator. She's not in right at the moment. So I'd just like to thank them. These coordinators work very hard to put together all the thousands of details that are necessary to provide you this opportunity to a wider audience by instituting the live stream for these meetings. So now I'd like to also introduce Dr. Subhash Dugarala. He is the medical advisor to the CMS HCPCS Work Group. Last but not least, we'd like to thank the man behind the booth, Mr. Felix, for handling all of our audio-visual needs on today. Now, before I describe how the meeting is going to proceed, I just want to inform you that GSA is repairing the exit lanes at the Security Boulevard gate from 7 a.m. to 12 noon. So anyone who needs to exit the main campus during this time will need to leave using the rear entrance on the Roll and Run Road. Okay. So we're going to describe how this meeting will proceed. Everyone should have received the meeting agenda upon arrival. If you have not, there are extras out on the table. For each item on today's agenda, there's a written summary of the application and CMS's preliminary coding decision inside of the agenda. The meeting will proceed one agenda item at a time until we have completed the agenda. We will hear a presentation from the registered primary speaker, if there is one, and any other 5-minute speakers, if there is one. For each agenda item, we ask that you will wait for questions until after we've heard from any 5-minute speakers. I would like to ask that every speaker state who you represent, state your relationship to the applicant and to the manufacturer, declare in your oral presentation and in your written summary whether or not you have any financial involvement with the manufacturers or competitors of any items or services being discussed. This includes any payment, salary, or other benefits provided to the speaker by the manufacturer. We'd like you to also state whether you agree or disagree with the preliminary decision, and when you summarize your comments, to state your rationale for your agreement or disagreement. After we've heard from all registered speakers, as I said, we'll invite questions and discussions specifically related to that item. So now, I'd like to start with agenda item number 1. Agenda item number 1, attachment 15.2. Request to establish a new level 2 HCPCS code to identify Balio deck. There is no primary speaker and no 5-minute speaker. Is there any questions regarding this item? Okay. Agenda item number 2, attachment number 15.22. This is a request to establish a unique level 2 HCPCS code to identify Blincyto. Primary speaker is Yola Garlick of Amgen.
Good morning. My name is Yola Golick. I'm a salaried employee of Amgen, and I'm the Executive Director of U.S. Health Policy and Reimbursement. I'm here today to discuss a need for a permanent Level 2 HCPCS J-code for our product Blincyto, which is a novel biological product that was approved by the U.S. Food and Drug Administration on December 3, 2014. Blincyto is a first-in-class anti-neoplastic immunotherapy approved for the treatment of Philadelphia chromosome-negative, relapsed or refractory B-cell precursor acute lymphoblastic leukemia. Blincyto is administered via continuous intravenous infusion using an external infusion pump. Amgen applied for a permanent level 2 HCPCS J-code for Blincyto effective January 1st, 2016, with the requested descriptor of injection blinatumomab 1 microgram. The CMS preliminary decision is not to grant a permanent level 2 HCPCS J-code, citing lack of operating need and the availability of a C-code for Blincyto for assignment by insurers. Amgen disagrees with the workgroup's preliminary decision. We believe there is a clear operating need for a permanent J-code and that the C-code is insufficient. I would like to briefly highlight the key points that demonstrate the operating need for a permanent J-code and also the issues with the C-code. To begin with, permanent level 2 HCPCS codes are essential for processing Medicare Part B claims and medical benefit claims for drugs in a timely, orderly, and consistent manner. In our HCPCS application, we noted that approximately 55% of Blincyto use is estimated to be in the home infusion, physician office, and hospital outpatient settings of care. These are settings of care that use permanent level 2 HCPCS J-codes for billing. Drugs and biologicals used in these settings of care are routinely issued permanent level 2 HCPCS J-codes. In particular, there is substantial precedent for issuance of permanent J-codes for drugs and biologicals delivered with external infusion pumps. In fact, CMS has issued or recommended permanent J-codes for all other drugs and biologicals that are covered under Medicare's durable medical equipment local coverage determinations for external infusion pumps. In addition, the Blincyto C-code is not a viable alternative to a permanent J-code because it cannot be used by all providers and suppliers of Blincyto. For example, C-codes cannot be used by Medicare durable medical equipment suppliers to bill for infusion pump drugs, nor by physicians billing Medicare for the drugs they administer in their office. If a permanent J-code is not issued, it means that some providers and suppliers and payers will need to continue to use the not otherwise classified J-codes for Blincyto. This will increase burden on providers and payers for claims processing and also will result in a missed opportunity for data collection. In the next few slides, I'll provide some additional information on Blincyto and the key points that I just summarized. So to begin with, Blincyto received FDA approval late last year on December 3rd, 2014. It's a bispecific CD19-directed CD3 T-cell engager indicated for the treatment of Philadelphia chromosome-negative, relapsed or refractory B-cell precursor acute lymphoblastic leukemia. Blincyto has orphan drug designation. It also received breakthrough therapy designation, priority review, and was approved under an accelerated approval. Continued approval for the indication may be contingent upon verification of clinical benefit in subsequent trials. Blincyto was actually approved quite rapidly by the FDA in a little over 2 months after submission to the FDA, approximately 6 months ahead of its PDUFA date. Blincyto is administered via continuous intravenous infusion using an external infusion pump. The typical dose is 28 micrograms per day, with the exception of the first 7 days in cycle 1 at 9 micrograms per day, and the infusion pump must be refilled every 24 to 48 hours. A cycle of treatment consists of 4 weeks of continuous infusion, followed by a 2-week treatment-free interval, and a treatment course consists of up to 2 cycles of Blincyto for induction, followed by up to 3 additional cycles for consolidation therapy. Blincyto is initiated in the inpatient setting. However, patients can be discharged and treated in outpatient settings. And in our application, we estimated 55% of Blincyto use will occur in home infusion, physician office, and hospital outpatient settings of care. A key reason why a permanent J-code is needed to facilitate timely and accurate claims processing is because of its use in these outpatient settings. Given Blincyto's dosing regimen, patients being treated in non-hospital outpatient settings will generate numerous claims or line items for Blincyto. This is because each pump refill will generate a claim or line item. Without a permanent J-code, each of these claims or line items would be billed with a not otherwise classified code and require manual adjudication. A key concern with the workgroup's preliminary decision is that no coding options will be available in some key settings. In our HCPCS application, we projected that home infusion and physician office settings, colored here in green and blue, would constitute approximately 19% of Blincyto use. It's still early since we've launched, but our sales data indicate that home infusion use has actually been greater at 27%. While the work group has identified the Blincyto C code as an option for payers, it is not actually an option for all providers and payers. Specifically, CMS guidance indicating which providers can bill Medicare using C codes notes that physician offices and DME suppliers are not allowed to use C codes when billing Medicare. Thus, even if other insurers allow the use of C codes, and I don't have any evidence on the extent to which other insurers are using C codes, it would still not address the needs of physicians and DME suppliers when submitting Blincyto claims to Medicare. As the work group is likely aware, home infusion drugs that are delivered by external infusion pumps may be eligible for Medicare coverage under Part B Durable Medical Equipment benefit. There are 4 durable medical equipment contractors, and all 4 have evaluated Blincyto and are covering Blincyto under the local coverage determination for external infusion pumps. Since Blincyto does not have a specific HCPCS J code, the DME MACs directs suppliers to submit claims using the not otherwise classified HCPCS code J7799. The pricing, data analysis, and coding contractor maintains the DME coding system, or DMACS, and identifies the codes that may be submitted to DME Medicare administrative contractors. The DMACS list includes many alphanumeric HCPCS codes, but notably absent from that list are C codes. Accordingly, C9449 is not available for assignment for DME suppliers that would furnish Blincyto to Medicare patients in accordance with the external infusion pump LCDs. Without a permanent J code for Blincyto, DME suppliers and DME MACs will continue to be burdened with manual claims processing using the not otherwise classified code. There also is substantial precedence for issuance of permanent J codes for drugs and biologics that are delivered with external infusion pumps. As just discussed, in order for a drug that is administered via an external infusion pump to be covered by Medicare, it must be added to the DME Medicare Administrative Contractor External Infusion Pump Local Coverage Determination by name. At this time, about 30 drugs have been identified within these LCDs. Most of these drugs are delivered intravenously like Blincyto, but some are delivered through other routes such as subcutaneous infusion or enterally. However, all of these drugs require external infusion pumps, and virtually all have permanent HCPCS J codes. In fact, there is only one other drug on these policies besides Blincyto that does not have a permanent J code, Duopa. Duopa is another new product that was recently added to these LCDs, and it is also included in the same set of preliminary decisions for today's public meeting. While the work group has a preliminary decision declining to grant a J code for Blincyto, the work group is recommending that a new J code be created for Duopa. Given that these 2 products are so similarly situated in that they were both recently added to the DME MAC external infusion pump LCDs, there is no basis for reaching contrary decisions. Both products should receive unique permanent HCPCS J codes. And given that every other product listed in the DME MAC external infusion pump LCDs has a specific J code and does not have to be billed with the miscellaneous J7799, as is true for these other products, there is a program operating need for a new J code for Blincyto. In preparing our HCPCS code application, we also reviewed the requirements for a permanent Level 2 HCPCS code as outlined by CMS in the HCPCS decision tree and definition, and Blincyto meets all the requirements. So in summary, Blincyto is a first-in-class anti-neoplastic immunotherapy, and it meets the requirements for a permanent Level 2 HCPCS J code. There is an operating need for a permanent Level 2 HCPCS J code for Blincyto to process claims in a timely and consistent manner. In our application, we estimated over 50% of Blincyto use would be in outpatient settings, including 19% of use in the non-hospital settings of home infusion and physician office. And sales data since launch indicate that home infusion use has been even higher, with 27% flowing through the home infusion setting. We understand that the work group sometimes does not create a new code for a drug and biological, citing the C code as sufficient when it believes that there is insufficient use outside of the hospital setting. However, the projected and actual use to date in the home infusion setting and the physician office setting should be more than sufficient to justify the need for a J code. In addition, the fact that CMS has determined there is an operating need to issue or recommend permanent J codes for every other drug and biological that is covered under the Medicare DME MAC external infusion pump policies is also strong evidence of the operating need to issue a permanent J code for Blincyto. And finally, the Blincyto C code is not a feasible alternative to a permanent J code because it cannot be used by all providers and suppliers of Blincyto, such as Medicare DME suppliers. We request that CMS issue a permanent level 2 HCPCS J code for Blincyto with the descriptor of injection blinatumomab 1 microgram effective January 1st, 2016. Thank you for your time this morning, and I would welcome any questions after the 5-minute speaker.
Okay, we have one 5-minute speaker, Dawn Serrano.
Good morning. My name is Dawn Serrano. I am the compliance manager for Walgreens Infusion Services. And for the record, I do not have any financial gains or involvement or have received any benefits from the manufacturer or competitors of any of the items being discussed today. And that we represent one of 2 preferred providers for Blincyto. And I am here today on behalf of Walgreens Infusion Services in hopes of influencing a change to the preliminary decision that Medicare has issued for not identifying a specific J code for Blincyto. We believe that there is a need to establish a new unique J HCPCS code to identify Blincyto, and that the C9449 is not adequate because it's designed for the hospital setting, and most private payers will use another miscellaneous NOC code in the absence of a unique J code. Not having a unique J code for Blincyto poses both administrative challenges, and more importantly, it impacts patient access to receive this drug in the home setting. First, I wanted to go into the administrative burden that's put on the provider, suppliers, as well as both Medicare and commercial payers. Billing with an NOC code increases the administrative burden for both the provider, supplier, and the payers because providers have to enter claim narratives, which can cause claim rejections. Payers have to manually process these claims. Claims with the NOC code are often denied, and they have to go through the appeals process. Payers require more time to process authorizations because they require this since it has no unique identifiable HCPCS code. And suppliers have to use more resources to obtain authorizations and coordinate with the referral source while the patient is waiting for that auth. It's a prolonged process, and it may take days to weeks to obtain that authorization, which would result in some patients staying in the hospital setting longer than they need to, or choosing hospice instead of returning home. And while the administrative burden is significant, the biggest reason that we are asking for CMS to create a unique J code for Blincyto is because of the negative impact that it has on patients. Patients having access to this drug in their home, and for them to get that within a timely manner. Patients may have to remain in the inpatient hospital setting longer than necessary. Patients would need a caregiver to drive them daily to the hospital for treatment, putting them at risk for infection. And again, unnecessary exposure in the hospital setting for immunocompromised patients. but really we want to emphasize that it keeps patients away from their loved ones and outside of that ideal quality of life. And lastly, I want to really talk about the possibility that the patients have to go through that administrative hurdle with getting that access and choosing hospice instead of home care, removing that hope and that holistic approach to their well-being and their healing process. Therefore, taking into consideration how assigning Blincyto its own unique J-code will effectively streamline the process for the administrative burden, but most importantly, giving patients access to this life-saving drug safely and effectively in the home setting. Thank you for your time this morning.
Okay, are there any questions or comments? Okay, thank you. Okay, before I move on to the next item, I'd like to ask that as we go forth, when the 5-minute speakers come forth, that they would take the microphone right here in the front of the stage. Agenda item number 3, attachment number 15.7, request to establish a unique level 2 HCPCS code to identify Cyramza. There is no primary speaker and no 5-minute speaker. Are there any questions or comments? Next, agenda item number 4, attachment number 15.4, request to establish a unique level 2 HCPCS code to identify Lemtrada. There is no primary speaker and there are no 5-minute speakers. Is there any questions or comments regarding this item? Agenda item number 5, request to establish a unique level 2 HCPCS code to identify Akenzio. Primary speaker, Stephen McMillan.
Good morning. My name is Steve McMillan. I am the Director of Federal Public Policy at AZI Inc., and I'm speaking in support of the CMS recommendations related to Akenzio. AZI distributes this product under license from Helsinn Healthcare SA of Switzerland. I have no slides for this presentation. I'm just going to speak in support of the recommendation. Akenzio is a fixed combination of 2 antiemetic agents, Nitupetant, a substance P neurokinin 1 receptor antagonist, and Polonocitron, a serotonin 3 receptor antagonist. Oral aprepitant is an FDA-approved antiemetic agent currently covered under Medicare Part B. It is an NK1. And Polonocitron is also covered under Part B as an infused product, Aloxi. CMS's decision to apply codes to this fixed combination ensures consistent treatment for antiemetic agents within this space. Akenzio was approved by FDA on October 10th of 2014. It is indicated for the prevention of acute and delayed nausea and vomiting associated with initial and repeat courses of cancer chemotherapy, including but not limited to highly emetogenic chemotherapy, otherwise known as HEC. Oral Polonocitron prevents nausea and vomiting during the acute phase, and Nitupetant prevents nausea and vomiting during both the acute and delayed phase after cancer chemotherapy. Akenzio is the first and only fixed combination antiemetic approved by the FDA and is recommended by NCCN as an option for first-line prevention in patients receiving both highly emetogenic chemotherapy and moderately emetogenic chemotherapy, also known as MEC. Each Akenzio capsule contains 3 tablets, each containing 100 mg Nitupetant and 1 gelatin capsule containing 0.5 mg of Polonocitron. 1 Akenzio capsule should be administered approximately 1 hour prior to the start of chemotherapy. In summary, Akenzio is a single-dose oral antiemetic combination targeting 2 critical antiemetic pathways consistent with antiemetic guidelines. Akenzio may provide convenience for both patients and prescribers and therefore has a potential to improve CINV control for patients. Akenzio is effective for the prevention of acute and delayed CINV in patients receiving cancer chemotherapy, including but not limited to HEC. We thank CMS and the coverage group for its consideration of our application and support the recommendations put forth. The agency's recent announcements related to payment reforms and the creation of a new oncology care model demonstrate your desire to focus on the appropriate care for cancer patients. Ensuring access to innovative and appropriate treatment options along the continuum of care, such as Akenzio, will enhance quality and improve outcomes. My colleague Haral Desai, pharmacist, and I are available to answer any additional questions you may have.
Are there any questions or comments? Okay, thank you.
Thank you.
Agenda item number 6, attachment 15.19. Request to establish a unique level 2 HCPCS code to identify Sylvant. There is no primary speaker and no 5-minute speakers. Are there any questions or comments regarding this item? Agenda item number 7, attachment 15.31. Request to create a unique level 2 HCPCS code to identify Rapivab. There is no primary speaker and no 5-minute speakers. Are there any questions or comments? Agenda item number 8, attachment 15.28. Second request to establish a unique level 2 HCPCS code to identify Ruconest. Primary speaker, Faith Dobson.
Good morning. My name is Faith Dobson. I'm the Director of Reimbursement for Valiant Pharmaceuticals, here today to support CMS preliminary decision to create a unique Level 2 HCPCS code for Ruconest. Valiant acquired, I'm a salaried employee of Valiant, as my disclosure. Valiant acquired Salix Pharmaceuticals on April 1st of this year. Salix submitted the original request for the new unique code for Ruconest, a unique recombinant C1 esterase inhibitor, on behalf of Santeris, who's a subsidiary of Salix and licensed for North American commercialization of Ruconest. Salix is located in Raleigh, North Carolina, and as I mentioned, was acquired by Valiant on April 1st of this year. We support CMS preliminary decision to establish a unique code to identify Ruconest and amenable to the unit increment included in that decision. To give a brief clinical background of Ruconest, Ruconest is a recombinant human C1 esterase inhibitor. It's unlike others currently available in that it is that are derived from human plasma, in that it is a recombinant analog of human C1 esterase purified from the milk of transgenic rabbits. Ruconest was approved by the FDA on July 16th of 2014 and is indicated for the treatment of acute attacks of hereditary angioedema, or HAE, in adult and adolescent patients, and it does exclude laryngeal attacks. Ruconest is manufactured in the Netherlands and distributed and marketed by Santeris, a wholly owned subsidiary of Salix. Ruconest is supplied in cartons of one single-use vial, each containing 2,100 units of lyophilized powder for reconstitution. It's administered as a slow IV injection over approximately 5 minutes and has weight-based dosing, as you can see here. In the majority of cases, a single dose is sufficient to treat an acute HAE attack. However, a second dose may be administered with no more than 2 doses administered within a 24-hour period. The company's request was that CMS establish a unique code for Ruconest injection C1 esterase inhibitor, as no existing HCPCS code accurately describe Ruconest. Existing J codes do not accurately describe Ruconest because they are derived from human plasma, while Ruconest is a recombinant analog of human C1 esterase purified from the milk of transgenic rabbits. Additionally, Coding will allow separate identification for Ruconest, which will enable facilitation of claims processing and reimbursement, and more importantly, provide access for adult and adolescent patients who suffer from acute attacks of HAE. The code will also allow physicians to accurately report and payer capture important product-specific information. With respect to CMS preliminary decision, we support this decision. Our initial request was that our code include a unit increment of per unit or one vial, simply because Ruconest is supplied as a single-use vial, and we wanted to minimize complication that would occur in billing, and due to the fact that a conversion factor is necessary due to the weight of the patient for treatment. We have considered CMS decision to a proposed unit increment of 10 units and support this decision. The unit increments is in line with those for other J codes for the other C1 esterase inhibitors, as well as for our C code long descriptor assigned to Ruconest in the OPPS setting. We appreciate the opportunity to present to the work group today regarding our response to your preliminary decision, and ask that you finalize your preliminary decision to establish the unique code for Ruconest for 2016. If there are any additional questions, feel free to contact me, or of course, if you have them now.
There are no 5-minute speakers. Are there any questions or comments? Agenda item number 9, attachment number 15.35, request to establish a unique level 2 HCPCS code to identify Duopa. Primary speaker, Paul Radinsky.
Good morning. I'm Paul Radinsky with McDermott Will, and we are outside reimbursement counsel to AbbVie, who is the manufacturer of Duopa. AbbVie, for those who aren't aware, was a pharmaceutical spinoff from Abbott a couple of years ago. Duopa is an intestinal enteral suspension formulation of levodopa-carbidopa. Levodopa-carbidopa has been used for decades now in the treatment of patients with Parkinson's disease, but some patients with Parkinson's disease, particularly advanced disease, still experience what we call off periods, where they have difficulty in movement and the symptoms of Parkinson's disease, which often are difficulty in initiating movement. So those are called off times. Also, one of the difficulties that patients have with treatments for Parkinson's is that they often have unwanted, uncontrollable movements that we call dyskinesias. And what you're looking for in treating patients with Parkinson's is to have the maximum amount of time, they say, on, where you have the effect of the agents in helping to keep patients mobile, active, but a limit and reducing the amount of time that you have patients where they have these unwanted movements. And so you're trying to maximize the on time without dyskinesias, reduce the off time, and that's what you look at in the clinical studies. Levodopa is actually the active ingredient. What happens is levodopa gets converted to dopamine, and dopamine in the brain is what is the treatment, because Parkinson's is a deficiency of dopamine in the basal ganglia in the brain. One of the difficulties with levodopa is that when you administer it systemically, it gets converted into dopamine in the systemic circulation, and not enough of it gets to the brain. And so many, many years ago, back before I was in medical school, I think even, and that's a long time ago, they came up with a combination formulation of carbidopa and levodopa. Carbidopa inhibits the breakdown of levodopa into dopamine in the peripheral circulation, so that more levodopa can cross the blood-brain barrier, get into the brain, and there be converted into dopamine to do its work. That's what levodopa-carbidopa is, and levodopa-carbidopa, as I said, has been around for probably around 40 years. One of the difficulties is, though, that a number of patients, as I said, still have difficulties with the medicines. So Duopa was formulated as an enteral suspension to be administered directly into the small intestine to avoid some of the changes and breakdown that can occur in the GI tract, and to have a continuous delivery of carbidopa, levodopa, so that you would have a more continuous blood level of it, and therefore in patients who are very advanced with Parkinson's disease, try and get them to have, again, more on time without the funny movements and a reduced off time. And that's what levodopa, carbidopa enteral suspension, Duopa is the brand name, is for. When you're giving levodopa, carbidopa, they're generally given in a 1-to-4 relationship, 1 by mass of 1 milligram of carbidopa for every 4 milligrams of levodopa. So we have the 4-to-1 ratio. This particular formulation for the enteral suspension, in order to have it administered, they have to first place a PEG tube, the percutaneous gastrostomy tube, into the stomach, and then they snake through from that into the small intestine, so that you have delivery directly into the small intestine of the enteral suspension gel. Each milliliter of Duopa contains 5 milligrams of levodopa and 5 milligrams of carbidopa and 20 milligrams of levodopa in the 1-to-4 ratio. And it's applied in cassettes of 100 mLs or 2,000 milligrams of levodopa. And it's given as a continuous infusion for 16 hours per day, and it's given through an infusion pump in the home. So this is an infusion drug as part of durable medical equipment. We submitted a coding application at the end of last year for Duopa with a recommended J-code descriptor of Duopa, carbidopa, levodopa, enteral suspension, 1-to-4 ratio per 5 milligrams carbidopa and 20 milligrams levodopa. Again, the importance of having the specific ratio there. The preliminary determination was quite close to what we had submitted, so it is JXXX carbidopa 5 milligrams, levodopa 20 milligrams, enteral suspension, and we support the preliminary determination. One thing that we wanted to call to CMS's attention right now, the only way that this is distributed is in 100 ml cassettes. So that's the 2,000 total milligrams of levodopa, and again, that 100 ml is administered so that essentially for most patients will have 1 cassette a day, and that's the only cassette put up that's currently available. However, for a number of reasons related to the kind of size of the product and getting it to patients, there's consideration possibly of having it available in 50 ml cassettes. And so we're just calling to CMS's attention that we're fine with the code description, but just calling as to what our interpretation of how that would work if we did have a 50 ml cassette instead of the 100 ml cassette. So if it were a 50 ml cassette and someone just got one of them, it would be 50 units, whereas with the 100 ml cassette, we would have 100 units. It's also possible that they could have a twice concentration, but still in the 1-to-4 ratio, so that you would have 10 milligrams of carbidopa and 40 milligrams of levodopa in the 50 ml cassette, delivering the exact same amount as you have with the 4 milligrams of, the 5 milligrams of carbidopa and the 20 milligrams of levodopa in the 100. And so both of those would be billed as 100 units. So again, we're fine with the descriptor. We think it will work, but we just wanted to call to CMS's attention that, as we always are looking with these descriptors so that you don't have to come back to the well, that we do think that it will work for possible updates to the cassette size, but we just wanted to make it clear what our understanding is of how that would work. So that's it. Thank you.
Are there any questions or comments? Agenda item number 10, attachment 15.36, request to establish a new level 2 HCPCS code to identify Lumazon. There is no primary speaker and no 5-minute speakers. Are there any questions or comments? Next, agenda item 11, attachment 15.20, request to establish a unique level 2 HCPCS code to identify Triferic. Primary speaker is Dr. Raymond Pratt.
Thank you. My name is Raymond Pratt. I'm the Chief Medical Officer for Rockwell Medical, and I'm a full-time salary employee of Rockwell Medical, the manufacturer of Triferic. I have no slides to present. Rockwell Medical is the manufacturer of tripsis-dependent chronic kidney disease. Triferic was approved by the FDA on January 23rd, 2015 as a maintenance therapy to maintain hemoglobin, as well as the first drug being approved to be administered via the dialysate to patients on chronic hemodialysis. For the committee, we would like to note that the USAN name assigned for Triferic is ferric pyrophosphate citrate. The name ferric pyrophosphate Citrex was pending at the time of the original CMS application and was changed by USAN to ferric pyrophosphate citrate just prior to the NDA approval. Rockwell Medical is here to thank the committee for their review of our application and preliminary coding decision to establish a new HCPCS code for Triferic, and we fully agree and support the committee's decision. And I'm available here to answer any questions about our product that you may have.
Are there any questions or comments? Thank you. Okay. Agenda item number 12, attachment 15.29, request to establish a unique level 2 HCPCS code for Zerbaxa. There are no speakers for this item. Are there any questions or comments? Agenda item number 13, attachment 15.30, request to establish a unique level 2 HCPCS code to identify Savextro. There are no speakers for this item. Are there any questions or comments? Agenda item number 14, attachment 15.34, request to establish a unique level 2 HCPCS code to identify Keytruda. There are no speakers for this item. Are there any questions or comments? Agenda item number 15, attachment 15.46, request to establish a unique level 2 HCPCS code to identify Opdivo. There are no speakers for this agenda item. Are there any questions or comments? Agenda item number 16, attachment number 15.38, request to establish a unique level 2 HCPCS code to identify Signa4 LAR. There are no speakers for this agenda item. Are there any questions or comments? Agenda item number 17, attachments number 15.41, request to establish a unique level 2 HCPCS code to identify Dalvance. Attachment number 15.17, request to establish a level 2 HCPCS code to identify Avycaz. There are no primary speakers for this item. We have a 5-minute speaker, Mr. Andrew Thorens.
Just made it. Good morning, everyone. I'm Andrew Thorens, and I head the reimbursement and market access function for Activist PLC. By way of disclosure, I'm a salaried full-time employee of Activist, and I am here in support of a unique level 2 HCPCS code for Dalvance, which is agenda number 17, as well as Avycaz, which is agenda number 29, through my oral comments and any written submission comments that we'll make to the HCPCS group. So first, Dalvance. Excuse me. Dalvance, which came through an acquisition of Duopa Therapeutics. That acquisition was done in October of 2014, is an affiliate of Actavis, and we are in fact requesting we're requesting that CMS create a new level 2 HCPCS code to specifically identify Dalvance for injection or dalbavancin 10 milligrams. Now, dalbavancin is a new drug as defined by the FDA. It was approved, sorry, I should learn not to do these things electronically and be green here. It was approved on May 23rd of 2014. Dalbavancin is a unique molecule with a distinct mechanism of action and dosing regimen. It's a semi-synthetic intravenous or IV lipoglycopeptide antibiotic administered as a once-weekly 30-minute IV infusion. Approximately 50% of Dalvance infusions will be in the physician's office, with the remaining in a home care setting, the ED or emergency department, HOPD or hospital outpatient department, and as I said, in home sites of care. Recognizing the unique molecular and therapeutic nature of Dalvance and the current specific C code is inadequate to describe Dalvance. So based on this and on behalf of Actavis, we are requesting that CMS create a unique permanent level 2 HCPCS code for Dalvance.
Go ahead into
Great.
29.
Oh, perfect. Thank you. Great. I'm also representing Avycaz in support of a unique level 2 HCPCS code for ceftazidime avibactam, and request a code for ceftazidime and avibactam 0.5 grams and 1.2 grams, respectfully requesting a preliminary decision. Avycaz is a combination of a cephalosporin and a beta-lactamase inhibitor indicated for the treatment of patients, adult patients, 18 years or older with the following infections caused by designated susceptible microorganisms. Complicated intra-abdominal infections used in combinations with metronidazole, and complicated urinary tract infections, including pyelonephritis. Avycaz is reserved for use in patients who have limited or no alternative treatment options, as only limited clinical safety and efficacy data are currently available. Avycaz is supplied in single-use vials containing 2 grams ceftazidime and 0.5 grams avibactam. FDA approved Avycaz on February 24th, 2015. And the approved label includes dosage adjustments for patients with renal impairment based on their creatine clearance level. Recommended dosages range from 2.5 grams, 2 grams ceftazidime, 0.5 grams of avibactam, to 0.94 grams, 0.75 grams ceftazidime, to 0.9 grams of avibactam. In each case, the ratio of ceftazidime to avibactam is 4:1. Therefore, the work group's preliminary decision to establish a unique J code for ceftazidime and avibactam, 0.5 grams that describes ceftazidime in combination with avibactam. There are no drugs currently available that have avibactam as an active ingredient. Since ceftazidime is still in clinical use and is a multiple source product, it would be inappropriate for providers to use J0713 to bill for ceftazidime avibactam, because it is a distinct innovator product with different FDA-approved indications and uses. And for those reasons, we respectfully request and support the preliminary recommendation of the work group to establish a unique level J code, ceftazidime and avibactam, 0.5 grams and 0.125 grams. Thank you.
There's a question. Any questions or comments?
I have a question. You meant 1 to 5 ratio. Is that accurate, rather than 1 to 4?
Great, thank you. So I hasten to add that my colleague, Travis Cooper, is also here to be able to address with some of the questions. And if you would kindly repeat the question, that would be great. Thank you.
Whether the ratio is 1 to 5 or 1 to 4?
So the ratio is 4 to 1 ceftazidime to avibactam, or 1 part avibactam to 4 ceftazidime.
Gotcha. Thank you.
Mhm.
Oh, and before you leave, can I get the correct spelling of your name?
Indeed. Thank you. Thanks, Cindy. Any other questions? Thank you.
Thank you.
Thank you.
Agenda item number 18, attachment 15.32, request to revise the descriptor of existing code J7302 to add brand name and duration of use. Primary speaker, Kevin O'Leary.
Kevin O'Leary, Vice President of Strategic Pricing and Reimbursement at Bayer Healthcare Pharmaceuticals. I'm a full-time employee and they pay my salary. Bayer manufactures Mirena, a 5-year intrauterine contraceptive device that has been available since 2001. Thank you for this opportunity to speak and to provide input to the coding process. Bayer's request is twofold. First, we ask that you revise the descriptor for J7302 to include the Mirena trade name and 5-year duration of use. Second, we urge you to assign a temporary Q code to Liletta, a 3-year IUD approved by FDA in February of this year. Separate codes will reflect the differences between Mirena and Liletta and facilitate appropriate treatment, billing, coding, and reimbursement of available IUDs. Bayer respectfully disagrees with the work group's preliminary decision not to modify the code descriptor. Circumstances have changed since we made this request. We believe the recent availability of Liletta and its implications, which were not evident when the work group made its preliminary decision, make a compelling case for a different final decision. Bayer applied for a J code for Mirena in 2000, and physicians have used J7302 to bill over 9 million units in the last 14 years. In February of this year, the FDA approved an NDA for Liletta. It is a single-source product. Section 1847A of the Social Security Act says, as appropriate, single-source products will be assigned a unique HCPCS code to facilitate separate payment. However, Liletta's manufacturer has not requested a code for Liletta and is actively distributing a billing and coding guide which advises physicians to use J7302. I have a copy of the guide and would be happy to submit that with my written comments. These events create an urgent need for more specific codes. First, to maintain patient and physician access to two distinct products that operate differently and have significant therapeutic distinctions. Second, to avoid billing and coding errors. Third, to prevent over and underpayment by Medicaid and commercial insurers, and to ensure accurate Medicaid rebate claims and program integrity. The crux of the issue is that J7302's descriptor does not reflect key therapeutic distinctions between Mirena and Liletta, and its wording should not govern whether both products share one code. The most important differences are the products' distinct labels and durations of use. Mirena is indicated for contraception up to 5 years and for treatment of heavy menstrual bleeding in women who choose an IUD. It also is recommended for women who already have had at least one child. Liletta is indicated for contraception up to 3 years. The products also differ in the amount of hormone released into the body each day. Looking at the products, you can see that the inserters are different. and I've brought examples of both products if you would like to see them. These are not interchangeable products, but the features that differentiate them are not captured by the inadequate wording of the J-code descriptor. Separate and distinct HCPCS codes are necessary to support appropriate treatment and patient management. Underlying existing payer coverage criteria is the assumption that J7302 is used to bill Mirena. For example, some state Medicaid programs limit payment to once every 5 years. Some health plans allow use of Mirena for heavy menstrual bleeding not associated with contraception. These criteria would not apply to Liletta. Coding, in this case, will affect patient and physician access to their contraceptive of choice because payers must pick a single reimbursement rate for each J-code. Health plans understand the differences between these products and have told Bayer representatives that they want to be able to reimburse them separately. But the reality is most medical benefit claim systems cannot pay by NDC. They have to pay off the J-code. With two products with different WAC prices paid under a single code, a payer choosing to pay off the higher WAC will create a large provider incentive to use the lower cost product. Paying off the lower cost product will put the buy and bill physician at a loss for the higher cost product. And I have an illustration. This chart shows the two scenarios I just described. On the left, higher payment assigned to a shared code creates a substantial profit incentive to use the lower cost product with no benefit to the payer. On the right, lower payment creates a loss for the physician, which again drives use of the lower cost product. The J-code governs reimbursement, which in turn drives physician prescribing behavior. In either scenario, a shared code will limit patient access to the product with the higher WAC, Mirena. Although I know cost should not influence your decision, I would note that Mirena actually costs about 20% less per year of contraception. If each product had a unique code, payers could maintain access to both products, and physicians would be able to prescribe based on the IUD's features and benefits, rather than its reimbursement as dictated by coding. Separate codes will ensure that women have access to a 5-year IUD with an indication for heavy menstrual bleeding Liletta does not have. That patients and physicians can accurately identify which IUD was used. I think you would agree it's important for a woman to know whether her IUD provides 3 years of contraception or 5. That women will avoid the risks of more frequent insertion and removal procedures required by an IUD with a shorter duration of use. That public and private payers reimburse in a way that does not unintentionally affect prescribing behavior. That patients and payers get the full 5-year benefit of Mirena when an IUD is billed under J7302. And that Medicaid claims are accurately reported. And let me explain this last point. Due to the 14-year, 9 million unit association of Mirena with J7302, and the rise of EMR and billing systems that automatically crosswalk NDCs to J-codes, physicians billing for Liletta under the same code may not enter the correct NDC on new claims. This will lead to state Medicaid programs receiving claims that appear to be for Mirena, but actually are for Liletta, and then submitting them to Bayer for rebate payments. We have good reason to believe this will happen, which I will illustrate on the next slide. In September of 2014, Bayer introduced a new inserter for Mirena with a new NDC, and we stopped distributing units with the old NDC. We're confident that the units with the old NDC were used up within 90 days. Nonetheless, February 2015 IMS claims data show 60% of reported Mirena claims still reflect the old NDC. Our hypothesis is that office billing systems have not been updated to reflect the new Mirena NDC, and that each claim is not scrutinized to ensure accuracy. We spoke with a medical billing software vendor who confirmed this was the likely cause. So we have reason to be concerned that claims for Liletta units billed under J7302 will list Mirena's NDC, and states will ask Bayer for rebates on those claims. This will lead to unnecessary confusion and disputes as we work with states to try and sort out which claims are accurate. In summary, we believe the confusion and negative implications of a shared J-code can be avoided if CMS amends the J7302 descriptor to include Mirena's 5-year duration of use and trade name, and promptly assigns a temporary Q code for Liletta. We also would request that you issue guidance to ensure accurate billing of these two products. Thank you for your attention.
We have one 5-minute speaker, Mr. Kent McKinney. Sir.
Good morning. My name is Kent McKinney. I'm Director of Federal Health Policy with Activists, and I am a paid employee by the company. And I want to thank the HCPCS committee for hosting this forum and for an opportunity to allow me to provide comments this morning. Thank you very much. Activists is supportive of the CMS preliminary decision to keep J7302 and the descriptive language contained therein as it is currently. The current coding description, 52 milligrams levonorgestrel, not only describes the Bayer product Mirena, but it also very sufficiently describes the Activist product Liletta, and it is not unique to the Bayer product. I think it's worth noting that this year alone, there have been in excess of 5,000 claims that have been approved for Liletta, and currently 15 million covered lives have access to Liletta using J-code 7302. And I would just note that many of the country's largest insurance companies, such as Aetna, Coventry, HealthNet, and numerous Blues plans cover Liletta by using J-code 7302. The previous speaker went at great lengths to discuss with you the confusion that not adding the descriptive language would provide when you compare a new product out in the marketplace, such as Liletta, to the existing product that's out there. I can scarcely conceive of a more confusing situation with all these lives under coverage than to add even greater descriptive language to 7302. And when I've clearly described to you that we have numerous lives currently under coverage by using J7302. Activists and Medicines 360, which, by the way, is a nonprofit pharmaceutical company, have established a unique partnership whereby the two companies make newly launched Liletta accessible to all IUD-appropriate women through their healthcare provider, including public health clinics enrolled in the federal 340B drug pricing program. Excuse me. We respectfully request that CMS finalize its preliminary decision pertaining to J7302. However, should the committee decide to change the coding descriptive language, we request that the committee establish a unique J-code that accurately describes Liletta to minimize potential disruption caused by the Bayer request. Thank you very much. I'll take questions. Thank you.
Okay, are there any questions or comments regarding this item?
Good morning. I'm Emeka Egwim, Lieutenant Emeka Egwim, pharmacist with the Division of Medicaid and obviously with the United States Public Health Service. I actually agree with the concerns of Bayer. Clinically speaking, these are two different delivery systems, where one is able to deliver the drug over 5 years and the other is able to deliver the drug over 3 years. It's the same drug, but delivered over different periods of time. And so to have the same J-code for essentially two different delivery systems or coverage over two different periods of time clinically doesn't make sense. I think it does make sense to kind of separate more importantly, have information that a clinician can look at, or a coder, an individual who handles billing, either for the state or for the healthcare facility, to be able to look at that and tell what's what. I, however, disagree with Bayer's proposal to include the name Mirena for J-code 7302. And the reason why is, for now, a levonorgestrel intrauterine delivery system that delivers the drug over 5 years is pretty much Mirena or nothing else, right? That's the only product that delivers this drug over 5 years on the market. But it is not unlikely that in the future there could be other drugs approved under an ANDA that also, well, not other drugs, but other products that also deliver the same drug over the same period of time. And that means that we will all be in this room again trying to further delineate, another J code for that product. 7302 is for Mirena, and then some other number for some other product. Doesn't really make sense to do that. So while I agree that Liletta should have a unique code, Q code, or another J code, I disagree with Bayer's proposal to delineate that 7302 specifically say Mirena. Thank you.
Thank you.
Agenda item number 19, attachment 15.9, request to establish a unique level 2 HCPCS code to identify Iluvien. There are no speakers for this agenda item. Are there any questions or comments? Agenda item 20, attachment number 15.10, request to establish a unique level 2 HCPCS code to identify Entyvio. There are no speakers for this agenda item. Are there any questions or comments? Agenda item number 21, attachment 15.12, request to establish a unique level 2 HCPCS code to identify Gelson. There is no primary speaker for this item. We have one 5-minute speaker, Christopher Jones.
Good morning. My name's Chris Jones. I'm here on behalf. Okay, that'd be great. Thank you. I'm here on behalf of IPSA Italia, the manufacturer of Gelson. I'm a salaried employee of the parent company Institut Biochimique SA from Switzerland. We agree with the work group's preliminary decision to establish a unique J code for the product, and respectfully request that you finalize that decision for the upcoming 2016 HCPCS code set update. Thank you very much.
Are there any questions or comments? Thank you. Agenda item number 22, request to establish another level 2 HCPCS code to identify Orbactive. Primary speaker, Mike McGuire.
Good morning, Mike McGuire from the Medicines Company, full-time employee, and thank you for the opportunity to talk to you today about the HCPCS code for Orbactive or Redavancin. The Medicines Company has requested the J code with the following descriptor injection for Redavancin 10 milligram. In its preliminary decision, the work group issued the requested J code, and the J code is consistent with the C code that is currently available. The Medicines Company agrees with the preliminary decision and respectfully requests that the work group finalize this decision. And the reasons are, we believe the issuance of the J code will really ensure patient access to a very beneficial treatment and has the potential to reduce healthcare costs in treating acute bacterial skin and skin structure infections. The issuance of the J code with the requested descriptor will eliminate current billing, reimbursement issues that have led to provider and payer confusion, delays and errors in reimbursement, and increased administrative costs. Oritavancin is a glycopeptide antibiotic that was approved by the FDA on August 6, 2014 for the treatment in adults of acute bacterial skin and skin structure infections. ABSSI infections are very common and seen in the hospital setting. And with the increase of methicillin-resistant Staph aureus, a number of these infections are caused by that organism. Orbactive is unique. It is administered as a single-dose treatment for the treatment of ABSSI. It's a single infusion of 1,200 milligrams, infused over 3 hours. There are other products on the market that also treat MRSA infections, but they require multi-dose courses of treatment and have to be administered over 5 to 28 days, where Oritavancin is one single injection. Since the first of this year, the C code for Orbactive Oritavancin has been available, but there's no existing HCPCS code, and so when administered to most non-Medicare patients or even to Medicare patients in the physician fee-for-scheduling setting, we see some issues, and they result in billing and reimbursement issues. Some real advantages with regards to Orbactive is that the patients receive a 1,200 milligram single infusion regardless of renal, hepatic impairment, age, gender, race, and weight. So there are no dosage adjustments needed, which actually reduces the potential for dosing errors. The single-dose formulation offers real significant advantages over other treatments for skin and skin structure infections that require multiple dosing. It increases actually the caregiver's ability to utilize the drug in multiple settings, such as the emergency room, observation setting, outpatient departments of hospitals, or even in the outside hospital settings such as physician-owned infusion centers, as well as home care. Now, the use of Orbactive may actually reduce some healthcare costs because of its single infusion, and it actually could reduce costs on follow-on therapy once patients are discharged from the hospital that may require an additional 5 or even greater days of IV therapy. It also eliminates costs associated with potential noncompliance because the single dose is the complete treatment that is given to that patient. So the J-code requested will solve a number of challenges that have been created with the miscellaneous J-code. As I mentioned before, we do have the C code available in the hospital outpatient setting, and at least for Medicare claims. In other settings, though, the providers are using the miscellaneous J code. This has resulted in some confusion among payers, specifically regarding the proper number of units to bill. It's common practice, as you know, to use a unit of 1 when entering the reimbursement under the miscellaneous J code. The provider then also submits additional information regarding that administration. The Orbactive administration requires the use of 1 full carton, which contains 3 vials of Oritavancin. And some payers are only reimbursing for the 1 vial, which leads to significant reimbursement reduction. This confusion has led to greater administrative costs, higher error rates, and delayed provider reimbursement. And unfortunately, in some situations, we know that the billing and reimbursement issues have discouraged providers from using Orbactive entirely. We're actually aware of one commercial payer that has provided at least 3 different reimbursement amounts for Orbactive. And as you can see, there's probably more current variability with regards to reimbursement. The National Correct Coding Initiative Policy Manual for Medicare Services has a billing unit of 1. There are some providers that are submitting units of 3, and there are some that are doing it by units, 1,200 milligram units, because each patient receives 1,200 milligram. And then there are some that are putting 120 units because the C code is out there in terms of providing information. And others are just taking a look at the invoice and using that as the reference. The variations, as you can see, in handling these unit issues associated with Orbactive have led to confusion and increased administrative costs. And this variability is across all types of payers. And we see it even with one of the MACs that has provided conflicting feedback as a provider. So by issuing this, we'll help ensure that the patients will receive appropriate care for the treatment of skin and skin structure infections. Currently, we see our Bactiv used at least 35% of the time in an outpatient setting. And what we see is that the C code is not sufficient enough in that setting in several states and private payers because they don't use C codes. So the issuance of the J code as the requested descriptor of 10 milligrams is necessary to have accurate billing. It'll also provide flexibility in terms of recommended dose deviations from the current 1,200 milligrams down the road. It also would avoid administrative issues by having to report a unit number that exceeds the number of digits that are available on the claim form. And it will eliminate confusion regarding whether to seek reimbursement based on the number of doses or the number of vials administered to the patient. So in summary, the medicines company supports the work group's preliminary decision to issue the J code, injection of Redavancin 10 milligram. The issuance of this J code will eliminate the current issues that we see with billing and reimbursement. And the product specific, sorry, these are new lips, just breaking them in. The product specific J code will actually coincide with the C code that we see. And for the reasons here, we respectfully request the work group finalize this decision. I'll take any questions.
Agenda item number 23, attachment 15.15, request to establish a new level 2 HCPCS code to identify Foxilum. There are no speakers for this item. Are there any questions or comments? Agenda item number 24, attachment 15.13, request to establish a level 2 HCPCS code to identify Hycuvia. There are no speakers for this item. Are there any questions or comments? Agenda item number 25, attachment 15.14, request to establish a unique level 2 HCPCS code for Obazur. There are no speakers for this item. Are there any questions or comments? Agenda item number 26, attachment 15.1, request to establish a new level 2 HCPCS code for Eloctate. There are no speakers for this item. Are there any questions or comments? Agenda item number 27, third request to establish a unique level 2 HCPCS code to identify Velitri. Primary speaker is Michael Flynn.
Good morning. On behalf of Actelion Pharmaceuticals, I want to thank you for taking the time to listen to us today. We're going to talk about Velitri for injection, and as I believe I'm the last speaker today, I'll be quite brief. I am a full-time Actelion employee. I'm the Director of Contract Analytics and Distribution. And Actelion is a Basel, Switzerland-based biopharmaceutical that has a current portfolio containing therapies to treat pulmonary arterial hypertension, or PAH, Gaucher's disease, and cutaneous T-cell lymphoma. Velitri is a unique product used in the treatment of PAH. PAH is a specific type of pulmonary hypertension. It's a rare syndrome characterized by a progressive increase in vascular resistance. The mean age at diagnosis is 36 years old, and the survival for untreated PAH patients is about 2.8 years. The available therapeutic options include medications, surgical procedures, and other types of interventions. The current treatments can only relieve the PAH symptoms and slow disease progression. At this point, there is no cure. And Velitri was approved by the FDA on June 27, 2008. Actelion submitted a request for a specific coding request because we do not feel that this, we do not agree, I guess, with CMS preliminary decision that existing code J1325 adequately describes the product Veletri. In the discussion of this application, CMS noted in accordance with the definition of therapeutic equivalence in the regulations, Veletri meets the definition of a multiple source drug. Actelion maintains that Veletri is not a multiple source drug since it has no therapeutic equivalence in the FDA's Orange Book, and Veletri was approved by the FDA under a unique NDA. We respectfully request reconsideration of this primary decision. Veletri does not meet the statutory definition of a multiple source drug. While we understand that Veletri has the same non-proprietary name as the other epoprostenol products, however, Veletri is not therapeutic equivalent to this product, to these products. Per 1847A of the Social Security Act, products must be therapeutically equivalent and pharmaceutically equivalent to meet the definition of a multiple source drug. For the first one, in general, multiple source drug means a drug for which there are two or more products which are rated as therapeutically equivalent in the Orange Book. The other relevant piece of this is that drug products are pharmaceutically equivalent if the products contain identical amounts of the same active drug ingredient in the same dosage form and meets compendial or other applicable standards of strength, quality, purity. Per the Orange Book, Veletri is not therapeutically equivalent to any other product and therefore is not a multiple source drug. This is a recent snapshot of the Orange Book, and note that there are a bunch of epoprostenol products, but Veletri is singled out as one that does not have a therapeutic equivalence code. And Veletri has a distinct stability and safety profile. Essentially, what makes it different is that it's got greater stability. And in June 2012, we introduced a new formulation of Veletri that has even increased that stability and safety that was already there even more over the other products. Right now, when Veletri is reconstituted, it can be stored for up to 8 days. The other epoprostenol-based products are stable for no more than 40 hours when reconstituted and refrigerated. That increased stability allows patients and healthcare providers to choose to receive fully reconstituted infusion pump cartridges from a specialty pharmacy on a weekly basis. Essentially what this does is the patient does not have to mix their drug at home. It can be mixed at the pharmacy under sterile conditions, and this creates greater safety. It reduces the risk of contamination, incorrect compounding by the patient, and mishandling of the drug product during preparation. The other products just can't do that because they're only good for 40 hours. So we respectfully request the creation of the following code effective January 1st, 2016. J-code injection epoprostenol, saline diluent, Veletri 0.5 milligram. Any questions, comments?
All right, thank you.
Thank you.
Agenda item number 28, attachment 15.39, request to establish a unique level 2 HCPCS code to identify Cresemba. There are no speakers for this item. Well, I know you all were looking forward to that coffee break, but I thought you'd be happier to get out of this meeting a little earlier. So having said that, we'd like to thank you again for your excellent and thought-provoking discussion and for taking time out of your very busy schedules to appear in person and to share with us all of your valuable input. Again, please remember that you cannot exit the main entrance here. You will need to exit using the rear entrance at the Rolling Road. And I'd like to say Happy Mother's Day to all of the mothers. Enjoy.